lecture exam and we finished section 1, so we're getting into section 2, which is thinking about circulation and control within the body, so covering both the cardiovascular and the nervous systems. There's a lot of commonality there, in part because the nervous system helps control and regulate the cardiovascular system, but also in that both of these types of tissue have the ability to initiate and propagate action potentials. So we're thinking about that idea of circulation and control. And we're going to start out by talking about the cardiovascular system. So in this PowerPoint and video that I'm posting today, we're just talking about the cardiovascular system. On Sunday, I'll post another lecture that's about the respiratory system, and then we'll change topics next week, talking more about blood and lymph. One other thing that will be posted this weekend will be kind of an overview of the lecture exam. I'm putting together some slides about the most missed questions with some resources on how to clarify those for the final exam. Remember, the final exam is semi-cumulative, meaning that a lot of it will be the most recent material, but there will be some of the most missed questions from the earlier lecture exams. All right, so to kind of overview what we're going to be doing over the next couple of lectures, today is just about the heart and the blood vessels, so thinking about the whole cardiovascular system. Sunday, like I mentioned, I'll post a lecture on the respiratory system. Today in lab, well, not today, tomorrow, sorry, you have your lab exam. And then next week in lab, you'll start looking into the cardiac cycle and blood pressure. So kind of expanding on the ideas that I'm covering in the lecture today. I wanted to kind of address the learning objectives because there is a lot of material, so I kind of want to give you a focus for how it all ties together. Just like usual, when we start a new chapter, I'll go over the sections that we're actually covering because we're not just going through the whole textbook. It's a combination anatomy and physiology textbook, so a lot of it is review that you don't need to spend time reading. That being said, I did post my anatomy slides, all of my anatomy resources for the cardiovascular system for this week's module. So if you are feeling like you don't really remember it from anatomy, if it's been a few years since you took anatomy, I would recommend going through the bullet points, seeing if there's anything that you don't remember from anatomy. And if you don't remember it, spend some time looking through those slides before you get into today's lecture. So these are the learning objectives. I'm not going to sit here and read them to you. I'll revisit them when we go through the section headers. So just a quick review from anatomy, not the full kind of review that's posted to Canvas. Remember that when we're thinking about the cardiovascular system, that cardio portion is referring to the heart. So thinking about heart anatomy, we have those atria at the top, the ventricles at the bottom, so superior and inferior respectively. Remember again, when we're talking about anatomical position, our right is the patient's left. So when we look at a drawing or diagram or picture of a heart, the left side is going to be on our right side. So keep that in mind. Today we'll talk quite a bit about some of those vessels that connect to the chambers. Remember that blood enters the heart into the atria from veins. Veins return blood to the heart. So the vena cava are going to feed the right atrium. The pulmonary vein feeds the left atrium. And then the right ventricle pumps blood into the pulmonary circuit through the pulmonary trunk, which branches off into the pulmonary arteries. The left ventricle pumps blood out into the systemic circuit through the aorta. Another thing to keep in mind is that we have a few different valves that we're paying attention to. So we have the semilunar valves, which are those valves that connect the ventricles and the arteries leaving the ventricles. So we have that pulmonary valve going from the right ventricle to the pulmonary circuit, and we have the aortic valve going from the left ventricle to the systemic circuit. We also have right and left atrioventricular valves. The right atrioventricular valve that separates the atrium and the ventricle, as its name suggests, is also called the tricuspid valve. On the left side, it's called the bicuspid or mitral valve. Remember that there's different cell types within cardiac muscle. This is because not only is it muscle, but it also has this property of self-excitation or autorhythmicity, where it's able to initiate and propagate action potentials. So we have myocardial contractile cells that are able to contract. So these are doing the muscly work of the heart. We also have myocardial conducting cells, which are really getting down to that autorhythmicity. The bulk of the cells in the heart are these contractile cells. They're able to conduct impulses, but they're not initiating them, and they contract heart muscle. The myocardial conducting cells are a smaller fraction of the cells, but they're going to make up a big system that we're going to talk about today. They tend to be pretty small. The exception to these are the PURKINJE fibers that we'll talk about, and they're able to initiate and propagate action potentials. So this is just kind of a picture of those. There's also intercalated discs, which separate out the different muscle fibers or cells within the heart, and they are important for allowing material to flow through so that the heart muscle is able to connect and coordinate movement. Remember that when we're talking about the cardiac cycle, there's kind of this atrial cycle and a ventricular cycle. Both of those go through systole and diastole. Systole is contraction when the heart is squeezing and those muscles are contracting. Diastole is relaxation, where the chambers are relaxing. Those are going to coordinate with readouts from an ECG or an EKG that we're going to talk about today. Remember that we measure our heart's work using cardiac output, or CO. We calculate that by multiplying our heart rate or our pulse in beats per minute, which is how frequently our heart is pumping, by our stroke volume, which is how efficiently our heart is pumping. So when you see the formula CO equals HR times SV, this is what that's referring to. I'm going to come back to this slide a lot throughout this lecture. Heart rate is pretty flexible. I think we've all probably had that experience of being nervous and feeling our pulse increase, maybe being on different medication or going to the gym and doing cardio activity and having our pulse increase. So this tends to be pretty flexible, but there are some limitations. There's kind of like a target pulse that you want to be at during exercise. Stroke volume tends to be more physiological. It's based in part on biological sex, fitness, heart size, and other physiological factors, but there are three really important things that affect stroke volume that we're going to talk about today. So in cardiovascular, we have the heart, but we also have this vascular component, which refers to blood vessels. So we have the arteries, which are moving blood away from the heart. Those get smaller and smaller in diameter and more numerous, getting into the arterioles and then eventually into capillaries. As exchange happens and flow continues back to the heart, those become venules and then transition into proper veins. So when we have our full circulatory pathway, we have that deoxygenated blood coming into the right atrium under low pressure, going into the right ventricle, and then getting pumped out under high pressure through the pulmonary trunk and pulmonary arteries into the lungs through the pulmonary circuit. That returns under low pressure through the pulmonary veins back to the left atrium. It's nice and oxygenated at this point, flows down into the left ventricle. That left ventricle is super muscly, it contracts and it pushes blood out through the aorta, through systemic arteries into arterioles and capillaries. It then returns through systemic veins under very low pressure, drains into the vena cava and returns to the right atrium. So make sure that you're familiar with that general flow. Okay, so starting with chapter 19, getting into the physiology of the heart. We're going to cover sections 2, 3, and 4. For cardiac muscle and electrical activity, you should be able to kind of trace the electrochemical flow of action potentials from the SA node. We'll get into that in just a moment. Until we get to ventricular contraction, you should be able to also interpret an EKG, which is the same thing as an ECG. In here, I mentioned them as EKG. In class, we'll try to refer to them as ECG. It's the same thing. I'll clarify that in just a moment. We'll also talk about the cardiac cycle and different phases of that, and then integrate that with readouts from an ECG, and then get into cardiac physiology, so recognizing factors that affect cardiac output indirectly by directly affecting heart rate and stroke volume. I will mention this again, but even though we talk about interpretation of an ECG, we'll talk about specific steps for that. You do not need to memorize the actual steps. We will try to provide you with those resources on an exam, because when you're in a hospital, you're going to have resources that help you interpret these readouts. You're not going to have to do it by memory. And so you need to be able to apply those resources, but you don't need to memorize those resources. Okay, so starting with the cardiac conduction system, usually when we look at a heart, we see all of those myocardial contractile cells, and we don't pay as much attention to the myocardial conducting cells. Remember that the contractile cells are about 99% of that heart muscle, and then we have a very small fraction that's the conducting cells. But here we're just looking at those conducting cells. So the cardiac conduction system is responsible for initiating electrochemical signals and then ultimately culminating in the contraction of the heart. So when we overlay that image that we just saw with the heart that we're familiar with, we can kind of see it in yellow here. So again, the myocardial conducting cells are kind of similar to neurons in that they're able to initiate and propagate action potentials. One important thing to keep in mind is that the fastest cells are going to set the pace. That will make sense in just a moment, but just think about maybe what you've heard about pacemakers as a medical device, kind of setting this consistent rhythm. So some important structures to pay attention to here are the sinoatrial node, the SA node, that's going to be the start of all of this, the atrioventricular or AV node, the atrioventricular or AV bundle, the AV bundle branches, and then the Purkinje fibers. Okay, so just kind of imagining the flow here, because I'm going to walk you through these different kind of areas and the flow of the signal. But here you can see it starting in the sinoatrial node, and you can also kind of see the relative position. So we have that sinoatrial node on the top right. The AV node is between the atria. That signal flows down to the bottom of the heart. Remember that another word for the inferior portion or bottom of the heart is the apex, that kind of point of the heart. And that's down at the ventricles. And then that signal is spreading to either side of the ventricles. To kind of tie that together with blood flow, we can see the firing and movement here, as well as the contraction and movement of blood. So I want you to kind of keep that black, white, and yellow GIF in mind as we're going through all these different steps so that you can kind of see how it flows together. Another important thing here is that there's kind of movement and pausing. That pausing is important for making sure that everything kind of contracts and fills up fully. Another thing that I wanted to remind you of are changes in polarization around a membrane and also active transport. So remember when we talked about cytosol, we said that the concentration of sodium is much higher outside of the cell, while the concentration of potassium ions is much higher inside the cell. So we're going to have in these sodium-potassium pumps movement of sodium outside and movement of potassium inside, both moving against their concentration gradient, so requiring active transport. So what this is showing you here is 3 sodium ions binding to this pump along with 1 ATP. The ATP is cleaved and then it becomes ADP. Sodium is pumped outside against its concentration gradient, and potassium is moved inside as the enzyme changes its shape and moves around. So oftentimes we focus on the movement of sodium ions and potassium ions. Here we're also going to be thinking about kind of longer opening calcium channels. So when we're thinking about action potentials in general, we're kind of thinking about these ideas of depolarization and repolarization around a membrane. I'm going to show you this GIF that's of a neuron, just because there's more resources available for those. You can kind of visualize this. So we see the charges around the membrane changing as it moves from the cell body towards the synapses. If we start to measure that charge, we see that charge becomes more positive through depolarization, and that is moving along the axon. And then when we map this pattern, we see that there's this moment of depolarization where the charge increases, the membrane potential increases, it becomes repolarized, and goes through this period of hyperpolarization. So this graph is something that's probably pretty familiar to you from studying action potentials in previous biology classes. Things look a little bit differently when you're thinking about the heart. So I mentioned those long-acting or slow calcium channels being open. So one effect of those is that the time it takes to repolarize and this refractory period before another electrical event or triggering of a contraction can occur again is much longer. So we have a much extended refractory period for cardiac muscle than we do for skeletal muscle, and this plot looks a little bit different. So in the bottom right, you can see the plot for skeletal muscle. There's a very quick peak of depolarization and repolarization, some hyperpolarization, and then going back to resting membrane potential. In cardiac muscle, because of those slow calcium channels, there's an extended period of repolarization, a longer refractory period before another signal can be sent, and this is very important so that you avoid these premature contractions or PVCs. These premature ventricular contractions cause kind of a fluttering feeling in the heart. They're not usually a problem, but if you have other underlying issues, they can lead to cardiomyopathy, so kind of weakening of the heart muscle or other arrhythmia. So it's really important for that those contractile cells, the cardiac cells, to fully contract before you get another signal being sent and you have this higher refractory period. Okay, so walking our way through the cardiac conduction system, we're just going to follow kind of that electrochemical signal, that signal being sent through the heart, starting at the sinoatrial node. So this is also called the SA node. This is where we have the highest rate of depolarization. So this is the node, the area that sets the pace of the heart. It's the pacemaker of the heart. So it's setting sinus rhythm, the normal electrical pattern, followed by contraction of the heart. So we have the SA node and the conduction system at rest. And then it's going to initiate that action potential and spread it across the atria. That's going to reach the atrioventricular or AV node, which again is located between the atria, so along the center axis of the heart. That receives action potentials from the SA node and passes them to the atrioventricular bundles. So if you remember to that GIF I showed you, the black, gray, and yellow one, there's kind of this firing and then a pause. And so when we have that pause, that delay, after reaching the AV node, that allows the atria to complete the pumping of blood. That will be important later when we talk about the cardiac cycle. So then we have the atrioventricular bundle, the bundle branches, and the Purkinje fibers. Keep in mind that the AV bundle is also called the bundle of His. That's another term for it. So all of these are basically responsible for receiving that action potential and then passing it on to the next step. The addendum to that is that the Purkinje fibers pass that action potential on to contractile cells. So that's when you're getting to the ventricles where you have this big contraction taking place. So you have that impulse being transmitted from the AV node to the AV bundle, bundle branches, and then Purkinje fibers. And then the Purkinje fibers spread that impulse to the contractile fibers of the ventricle, and you have ventricular contraction. You have contracting of those ventricles of that really thick muscle along the apex. So this happens kind of like squeezing a tube of toothpaste, kind of going from the apex of the heart upward. Remember that even though we draw simple diagrams like the kite diagram, which if you've taken anatomy with me or looked through the slides you might have seen, even though things like the aorta and the pulmonary trunk connect to ventricles, which are at the base of the heart, they are actually situated towards the top of the heart. And you know, I just misspoke. I'm so used to saying base in like day-to-day conversation. The base is actually the top of the heart, the apex is the bottom of the heart. I know that's confusing, but the contraction goes from the apex to the base, so from the bottom to the top to push that blood outward, like into those arteries, like squeezing a tube of toothpaste. So when we're thinking about how to clinically record the activity of this conduction system, we use something called an ECG. This stands for electrocardiogram. You might have heard it called an EKG before, and I used both of those terms earlier, ECG and EKG. Those mean exactly the same thing. They are both referring to electrocardiogram. EKG just comes from the German spelling with electrocardio with a K, electrocardiogram. ECG and EKG are the exact same thing. I'm hopeful that you'll listen to this and that you'll remember that. If you see them separately or just one or the other, know that they mean the exact same thing. So when we look at these ECGs, we see consistent patterns. We'll start to kind of look at different components of that pattern and what they stand for, and start to kind of figure out what that tells us about the cardiac cycle and patient health. So some of the images that I show you will be kind of the simplified diagram, not on grid paper. When you look at EKG or ECG readings in class or in a hospital, it will be printed on grid paper, which is important because that allows us to kind of look at time frame, tie that back to the cardiac cycle, and interpret it accordingly. So when we look at different waves or intervals or segments, segment is referring to a region between two waves. So for example, we have the PR segment, there's a P wave and an R wave. The gap between those is the segment, PR segment. An interval is a segment and one or more waves. So for example, we have the QT interval, which is going from that Q dip to the end of the T wave. So we have an interval, a segment there. So we have the R wave and the T wave, and then we also have other components there as well. The QT interval actually is pretty important because that's the time from when the ventricles relax to when they start to contract again. And there's actually a lot of medications that affect the QT interval. So if there's kind of an extended QT interval, that's a type of arrhythmia. It can be very dangerous, so you might want to pay attention to that. Remember, we're kind of tying this in with the cardiac cycle. So different waves are generated at different parts of the cardiac cycle. All right, so when we're looking at the P wave, you can kind of see this little generalized ECG reading here with P, Q, R, S, and T. That little bump that's the P wave represents depolarization of the atria. And then shortly after that P wave is when we have atrial contraction. So you can look at that P wave on a printed ECG readout and understand that that's depolarization of the atria and that we're expecting the contraction of the atria. So the start of atrial systole to begin about 25 milliseconds after that. Then we have the QRS complex, so that Q dip, the R peak, and the S dip. That represents depolarization of the ventricles. It goes up much higher because there's a stronger electrochemical signal there. The ventricles are actually contracting at that peak of the R wave. and we have repolarization of the atria occurring here as well. So remember that the P wave indicated depolarization of the atria. Somewhere in this QRS complex, we have repolarization of the atria, but it's masked by the QRS complex from the ventricular cycle. Then we have the T wave, which represents repolarization of the ventricles. We can see this, it's not masked by anything. Okay, so one thing to keep in mind is that the cardiac cycle is dependent on pressure gradients. So we have these electrochemical signals, we have muscles contracting, and that muscle contraction is important because it changes the volume of these chambers and it affects the pressure within them. So remember that fluids move from areas of high pressure to low pressure. So you can kind of think about like when you turn on a hose and you put your finger or your thumb over the entrance of the hose or the opening of the hose, you create this very high pressure area, and so the water is going to kind of spurt out and go from where it's under a lot of pressure to where there's less pressure. So that's something similar is going to happen in the heart. Fluids are going to move from areas of high pressure to areas of low pressure. So again, as cardiac muscle contracts, it changes the volume of those chambers and it changes the pressure gradient of those chambers relative to the vessels that they're connected to. So that change sets up this pressure gradient and it allows us to keep the flow of blood going in a consistent manner. All right, so I'm going to kind of work my way through this diagram. We're going to keep going back to it and just rotate around that cardiac cycle. We're going to actually start here with atrial systole, which is contraction, and diastole, which is relaxation. So on this chart, one thing to keep in mind is, so we have the atria doing something, with the ventricles doing something. The yellowish colors represent what the atria are doing. The green colors represent what the ventricles are doing. So we have atrial systole and atrial diastole. So this is happening again after the P wave. Remember, about 25 milliseconds after the P wave, we have that first atrial contraction. So the atria are actually filling with blood throughout their relaxation period, throughout atrial diastole. Remember that blood flows into the atria from veins, so the vena cava and the pulmonary veins, but they're not going to fill all the way until we have that actual atrial contraction. So the last 20 to 30% of that chamber is filled as the atria contract during systole. So then the atria are going to return to diastole. There's that repolarization, but again, it's masked by the QRS complex. So then we have ventricular systole, which is a little bit more complex than atrial. This is going to follow depolarization of the ventricles at the QRS complex. One thing to keep in mind here is this idea of preload. So at the very start of ventricular systole, you have what's called end diastolic volume, or EDV. So this is at the end of diastole, the beginning of systole, the amount of blood that's in those ventricles. So it's the preload, it's the load at the start of systole. So this ventricular systole is actually divided into two phases, kind of depending on the pressure and volume of the blood. This first phase is called isovolumic contraction. It's also called isovolumetric contraction, and when you look at that word, iso means the same, volumic or volumetric means volume. So in this, the volume of blood in the heart remains constant. It's not changing. So the reason for that is that we have these semilunar valves, like we talked about earlier, the pulmonary valve and the aortic valve. The pulmonary valve is connected to the right ventricle, the aortic valve to the left ventricle, and the pressure within those ventricles is actually not quite high enough to move the blood through those valves. So we don't have enough of a strong pressure gradient yet. So the blood's actually going to kind of flow backwards a little bit towards the atria. But remember, those valves, the tricuspid valve and the mitral valve, are unidirectional. So they're not really facilitating that backflow. So it closes those atrioventricular valves. It's going to kind of flow up against them, but then close the bicuspid and tricuspid valves. And so that's going to allow pressure to build as blood volume remains constant. So then you have the second phase, which is ventricular ejection. So the blood is actually going to be able to leave the ventricles at this point. So the ventricles are going to keep contracting. So volume's constant, ventricles are contracting, pressure is building, and so finally at this point you have enough of a pressure gradient to eject that blood through the aortic valve into the aorta and also the pulmonary valve. So the blood from the left ventricle is going into the aorta, blood from the right ventricle is going into through the pulmonary valve into the pulmonary trunk. So this is called stroke volume, the amount of blood that's actually leaving at this point. One tricky thing though is that when we talk about cardiac output or stroke volume, we're just talking on average one ventricle or one chamber at a time. We're not thinking about the whole heart. So just one circuit or one ventricle at a time. So one calculation that we take into account here is the end systolic volume. Remember we had end diastolic volume, now we have end systolic volume. So this is the amount of blood that remains in the ventricle following the completion of systole. So after it's contracted, there's still some blood left in the ventricle. That's the ESV, the end systolic volume. So we'll come back to that when we talk about stroke volume and effects on cardiac output. All right, so after that contraction, we have relaxation, we have ventricular diastole. So this is following repolarization of the ventricles and occurring at the T wave. So this also has phase 1 and phase 2. In phase 1, we have the valves closed. So again, it's kind of isovolumic. The volume of blood is maintained. It's remaining consistent. It's isovolumic. And then we have phase 2, where the ventricular muscle fully relaxes, blood pressure drops, the chambers are going into diastole, they're relaxed. The atrioventricular valves, so the bicuspid and tricuspid valves open, and the semilunar valves are closed. So when we kind of look at this ECG reading and we see the P wave, the QRS complex, and the T wave, we see that that P wave is happening right between atrial diastole and atrial systole. The transition from atrial systole to atrial diastole happens in the middle of that QRS complex, but remember it's being masked. The transition from ventricular diastole to ventricular systole happens in the QRS complex as well, and then the transition from ventricular systole to ventricular diastole happens at the end of the T wave, and that's one full cardiac cycle. So when we're reading that ECG, these are printed on grids. There's really small boxes and bigger boxes. So you can see the small box highlighted in the bottom right and the large box highlighted in the top right. One small box is representing 0.04 seconds or 40 milliseconds. The amplitude or the height represents millivoltage. Each tiny square is going to represent 0.1 millivolts in amplitude and 0.04 seconds, which is 40 milliseconds. You can kind of see the bigger grid lines as well. So the heavier line width, those are representing 0.5 millivolts and 200 milliseconds or 0.20 seconds each. So the number of squares is going to be important in kind of figuring out these baseline measurements that are part of the 8-step method. So the 8-step method is an important tool for interpreting ECG readings. One thing that I'll say is that this is an important learning outcome of the course, learning how to apply the 8-step method. But there's different strategies for reading ECGs. The printouts look a little bit different depending on how many leads you're using, how many sensors you have on the patient. I'm going to provide you with some resources, and I'm going to provide you with kind of the method to follow. the method that Michelle shows you in lab might be slightly different, or she might have different pointers for you. I'm also going to include kind of a database with normal ECGs, which is where this printout is from. It also has tons of examples of ECGs from very specific heart conditions, so that might be worth looking into and starting to practice noticing differences between normal and abnormal or atypical ECGs. Another thing you can look at is if you go onto Amazon for $2.50 about, you can get a little thing that attaches to your hospital ID badge. It has calipers on it, it has different rulers on it, and it has tips for reading ECGs. So you can actually have a resource clipped onto your hospital ID badge. Okay, so I'm going to walk us through this 8-step method, but again, you don't have to memorize these steps. You'll have the resources in front of you in lab. So the first step is to evaluate the P wave. And remember that the QRS complex is probably the easiest thing to find because it's kind of a dip down, a peak, and then another dip down. And then you can see the smaller wave kind of set in front of that. And that smaller wave is the P wave. So there you can look at the size, the shape, the location in the waveform, and then once you kind of start to get a feel for it, get a feel for how it should be sized and shaped, you can start to get a little bit more quantitative about this. Again, here's a couple of links. There's the ECG database that I mentioned. It's worth looking into. And then I adapted these slides from this 8-step method link. So that is another thing that's worth looking into as well. So then you start looking at the atrial rhythm. Remember that the P wave tells us about atrial contraction because atrial contraction is happening consistently about 25 milliseconds after the P wave. So we kind of get a feel for atrial rhythm using the P wave. So we can look at the PP interval, so going from one P wave to another, being consistent about where we're measuring it, and then from that P wave to the next one to see if that's consistent. So the P wave should be occurring at regular intervals. We can then get very quantitative about this and determine the atrial rate. I included a formula that's a quick way of calculating. So you can take 2 3-second segments, count the number of P waves in those segments, and then multiply that by 10. Or you can count the number of small squares between the apex of 2 P waves. So within the PP interval, you can count the number of small squares. So then you can divide that number of small squares by 1500 to get the actual atrial rate. The next step is to calculate the duration of the PR interval. So that's the distance from the start of the P wave to the dip of the QRS complex. So you can do this by counting the number of small squares from the beginning of the P wave to the beginning of the QRS complex and then multiplying that by 0.04. So a normal range is 0.12 to 0.20 seconds, which is about 3 to 5 squares. And then if you have a higher number of squares than that between the P and the R, so the PR interval, then that is indicating delayed conduction of the impulse to the ventricle. Remember that the P wave is kind of showing us a little bit before, or it's showing us depolarization of the atria. The QRS complex is showing us depolarization of the ventricle. So if there's a bigger gap between them, then it's taking a little bit too long for that signal to be sent from the atria to the ventricles. So after that, we evaluate the ventricular rhythm. You measure the RR interval at the same exact point of multiple QRS complexes. So because here you're looking from one complex to another, as long as you're consistent about what part of the QRS complex you're measuring, that's all that matters. And so if you have a consistent RR interval, then you have a consistent ventricular rhythm. After that, you get quantitative, you determine the ventricular rate. So you use that same formula I showed you earlier. At this point, you can also check the shape of the QRS complex to see if it's what you're expecting. Then you can calculate the full duration of the QRS complex. So you count the squares between the beginning and end of the QRS complex and multiply it by 0.04 seconds. And the normal value is less than 0.12 seconds. Remember that the QT interval is important, so this is kind of starting to get into that. Being able to identify arrhythmias and abnormal lengths of these cycles. So then finally, you calculate the actual QT interval. So you count the number of squares from the beginning of the QRS complex to the end of the T wave, multiplied by 0.04 seconds. And again, the normal range is 0.36 to 0.44 seconds, or 9 to 11 small squares. Remember that this one is very important. There are a lot of medications that affect the QT interval, so it's worth knowing whether your patient is taking any of those medications and paying attention to the ECG. If you have any issues with that, it can lead to sudden death, so it's definitely something to look out for. Okay, so that was the 8-step method. Again, the way you approach it in lab might be a little bit different, and the way you approach it as a practicing nurse might be even more different. So there's just different things to look out for depending on what type of setting you're working in, what types of patients you're coming into contact with. So here we're kind of showing you strategies to use and tools to kind of keep in mind, ways of approaching this. But on an exam, I'm not going to have you use the 8-step method by memory. I might ask you specific questions, but I'll give you the tools, I'll give you the steps about how to do that on the exam. So in a clinical setting, you also listen to the heart. So when we're kind of thinking about a normal heartbeat, we kind of think about lub-dub, lub-dub. Those sounds actually mean something quite important, and they have their own set of nomenclature. So the lub is called S1, and that represents ventricular contraction. It's the sound of the AV valves closing. The dub is called S2, and that represents ventricular relaxation, and that's the AV valves opening and the semilunar valves closing. So we can actually hear those valve sounds as lub-dub, lub-dub. So there's S1 and S2. There's several other S sounds that you usually only hear in very young patients, pregnant patients, and patients with very particular types of dangerous medical conditions. Usually we just focus on S1 and S2. So when we talk about a heart murmur, that doesn't mean one thing specifically. It's any unusual sound coming from the heart. And then once you identify it, you can kind of start to target it further and identify it further using a technique called auscultation. So if you've ever been in the hospital and had to have someone put a stethoscope on your chest in very specific locations and have you breathe in and out, that was to amplify the sound in different parts of your heart. And so you put the stethoscope at the aortic valve, the pulmonary valve, the tricuspid valve, and the bicuspid or mitral valve to kind of try to see where the issue is coming from. So we have ECGs as a tool. We also have heart sounds as a tool. Okay, so thinking about what's actually affecting cardiac output. Again, I've shown you this slide before. Remember that cardiac output, or CO, is determined by multiplying heart rate, the frequency of our heart pumping, by stroke volume, the efficiency of our heart pumping. So the way that we actually measured those, so cardiac output is the amount of blood pumped by each ventricle in 1 minute. So remember, this is just one ventricle at a time, not the sum of both ventricles. It's the average of those. Then the heart rate is measured in beats per minute, or BPM, so the contractions of the heart per minute. Stroke volume is the volume of blood leaving the ventricle on average, so referring to a single ventricle on average. So we're looking at that volume per unit time. So on average, the mean cardiac output from each ventricle is about 5.25 liters per minute. One other thing to keep in mind with stroke volume is that you can use this to calculate ejection fraction. You calculate that by dividing stroke volume by the end diastolic volume, or the preload, which we talked about earlier. That metric is important because it can be used for diagnostics, and also if you're aware that a patient has heart failure, you can kind of keep an eye on that measurement and use it to kind of quantify how they're doing. On average, the ejection fraction is about 50 to 70%. So while heart rate and stroke volume are directly affecting cardiac output, there's many other factors that affect heart rate and stroke volume individually. So they are directly affecting heart rate and stroke volume and indirectly affecting cardiac output as a result. Remember that heart rate is very flexible. We can change our heart rate by holding our breath, by jogging around the block, by taking medication, by getting cut off in traffic. All sorts of things affect heart rate. So that is affected by our nervous system, autonomic innervation, hormones, fitness levels, age, medication, many other things. Stroke volume, again, is a little bit more physiological. It's a little bit less flexible. It's affected by heart size, fitness levels, your biological sex, but also contractility, duration of contraction, preload, and afterload. So we're going to focus on contractility, preload, and afterload. Contractility is the forcefulness of the contraction of the heart that affects end systolic volume. And when we have different factors or different components that affect contractility, those are called inotropic factors. With preload, we talked about that already. It's the end diastolic volume. So that's the stretch that's placed on the heart before it contracts. So one powerful factor that affects that preload or end diastolic volume is the filling time. Remember that preload is the volume of blood at the end of diastole or relaxation, and if you have blood entering into the ventricle in that relaxation period, if you have a shorter filling time, a shorter duration of that period, you're going to have a much smaller preload because you have less blood at the end of that short period. Afterload is kind of the resistance that the heart is facing, so it's the pressure that must be exceeded before ejection can begin. So remember, there's those two different phases. There's the isovolumic and then the ejection phase. And so before that ejection can begin, that pressure has to be overcome. So factors that increase resistance increase afterload. All right, so this is a lot of extra information. So these are just all the major factors that we just talked about, preload, contractility, and afterload that affect stroke volume. So a little bit more information there. And then kind of how this all relates together with cardiac output. All right, so getting into the second part of the cardiovascular system, the vascular part, the blood vessels. We'll start by talking about blood flow, blood pressure, and resistance. So starting to identify those factors that influence blood flow and pressure, relate those calculations to the cardiac cycle, and understand clinical approaches, and then get into how do we actually homeostatically regulate the vascular system. So looking at neural, endocrine, and autoregulatory mechanisms of blood flow. There's going to be some stuff that I'll briefly mention, but that we won't get into until we talk about other systems. So I'll clarify that when we get to it. All right, so remember again, in this cardiac cycle, we have systole and diastole. So you might have heard of those terms more consistently in conversations about blood pressure. So not necessarily thinking about what's happening in the heart, but maybe thinking about blood vessels. So when we're thinking about blood pressure, what this is referring to is hydrostatic pressure in blood vessels. So it's the pressure that blood is exerting on vessel walls, and you can actually measure it at many different places, but we measure it at the brachial artery, so measuring systemic blood pressure, or more specifically, systemic arterial blood pressure. So systemic arterial blood pressure is measured at the brachial artery. That's why we measure it at the upper arms, like is indicated in this GIF that I'm playing. We measure it in millimeters of mercury. So this term resistance is defined as the opposition to blood flow as the result of friction. So that's another thing to keep in mind. All right, so when we collect data about blood pressure, one thing that we can actually calculate is pulse pressure, which is an important metric for patient health. So we actually calculate that by subtracting the diastolic pressure from the systolic pressure. And so when we have a low pulse pressure of less than 25%, that indicates low stroke volume. It might indicate congestive heart failure, stenosis of the aortic valve, or blood loss. So the numbers themselves are important, but also the difference between the numbers is also important. If you have a short incidence of very high pulse pressure, so a greater difference between the systolic and diastolic pressures, that might just be indicative of having a high stroke volume after exercise. But if it's chronically high, that indicates resistance in the arteries or many other disorders. And having that chronic high pulse pressure can cause damage over time. So we can see in this plot also that in systemic arteries, there's a pretty consistent gap between the systolic and diastolic pressure, so we can meaningfully calculate something like pulse pressure, whereas if we were measuring in the arterioles or the veins, there would be no appreciable difference between systolic and diastolic, so we wouldn't have consistent numbers to work with. We can also use systolic and diastolic readings to measure mean arterial pressure, which you can see as kind of a gray line indicated on this plot. That's the average force driving blood into vessels that supply our body tissues. And we can calculate this using the formula mean arterial pressure equals diastolic blood pressure plus systolic minus diastolic blood pressure divided by 3. This is a good measurement to keep in mind. A normal mean arterial pressure is about 70 to 110 millimeters of mercury. A low MAP value is less than 60. And so this kind of gives us information about blood flow, about blood force. Low measurements are indicative of ischemia or insufficient blood flow, which can then lead to hypoxia or inadequate oxygenation because you're not having that fresh oxygenated blood flowing into body tissue. So when we're measuring that blood pressure, we're doing so with a machine called a SPHYGMOMANOMETER. That is a mouthful. Just pretend like the H isn't there, so SPHYGMOMANOMETer. And that's that cuff and measuring device that you're probably very used to seeing, and also a stethoscope. And hospitals have different levels of technology for this. There's kind of old-fashioned blood pressure machines or more modern ones with digital readings. So basically, you're going from the time when you cut off blood flow and can hear sounds to when blood flow resumes and you can't hear sounds anymore. So the sounds that you're hearing are called port cough sounds. And so they represent the flow of blood through vessels. Basically what you do is you tighten that cuff, you cut off the flow of blood, and the first sound that you hear represents systolic blood pressure, so it's that first measurement you get. Air is slowly released from the cuff over time, and so you hear less and less of those sounds. They decrease in amplitude, and the last sound you hear represents that diastolic blood pressure. So at that point, the blood is flowing freely, and you stop your measurements. So it goes from where you hear sounds to where you don't hear sounds, systolic and diastolic respectively. Okay, so again, just reminding you of this formula, cardiac output is equal to heart rate times stroke volume. So when we're thinking about variables that affect blood flow and blood pressure, one thing to consider is cardiac output. So remember, this is measured in liters per minute. So that is one thing to consider, is the cardiac output that affects blood flow and blood pressure. Another thing that affects it is compliance. I should say that the reason the cardiac output affects blood flow and blood pressure is because if you have different output from your heart, there's going to be, different flow of blood and different pressure. So hopefully it's kind of intuitive to you. So the amount that's coming out makes a difference in what's going into the vessels themselves. Another thing to consider is compliance. So if we look at this cross-section of arteries and veins, we can see that the artery is very reinforced, very muscly relative to the vein. The vein is very floppy. And so if we have stuff flowing through here, we could say that the artery is probably less compliant, less flexible than the vein. So veins are more compliant than arteries. So compliance is kind of just this ability to increase and be flexible in size and expand. Non-compliant arteries are not able to increase and decrease in diameter and size. So when we have things like vascular disease, those might decrease arterial compliance. That in turn increases resistance because you have more resistance, it's less compliant. That in turn increases blood pressure and reduces blood flow and increases the work that the heart has to do. So one example of vascular disease is atherosclerosis. We can see that diagrammed here, where we have a narrowed artery and buildup of plaque, which reduces compliance and expansion, increasing the work of the heart. So a few more factors that affect blood flow and blood pressure include the volume of blood. So remember, we talked about that first in terms of cardiac output, the volume of blood that's leaving the heart and entering the vessels, but total blood volume also makes a difference. So volume, the volume of blood, blood pressure, and blood flow are all directly proportional to one another. So as you increase blood volume, you increase blood pressure, and you increase blood flow. When you have very low blood volume, like after a hemorrhaging event, it's very dangerous. That's called hypovolemia. So hypo is low, like hypotonic or hypodermic needle, and then hypervolemia is high blood volume. We also have blood viscosity, which is kind of how sticky that blood is. So when you increase the thickness or the stickiness of the blood, that increases resistance and decreases flow. So becoming kind of more syrupy and thick, the blood's not going to be flowing as well. So this is affected primarily by formed elements, so like cellular components of blood, like red blood cells, white blood cells, and platelets, erythrocytes, leukocytes, and thrombocytes respectively, and then also plasma proteins. So the length of the vessel and the diameter also makes a difference. The length matters because as you have more length to the vessel, there's more surface area. So the blood is being pumped out of the heart. It has to make its way through these different vessels, and the longer it passes through, the more surface area there is, the more surface area the blood encounters. There's more resistance and decrease in flow over time. So think about how low the pressure is and kind of low the flow of blood is in your feet and extremities. And then with diameter, when you have high diameter, kind of closer to the heart of those vessels, you have a lower surface area to volume ratio that decreases resistance and increases flow. But then over time, the diameter decreases as we transition from arteries to arterioles to capillaries. And so when you have those types of vessels, you're going to have lower flow, increased resistance. But that's very important because then you have a lot of exchange. That's where exchange between blood and surrounding tissues actually occurs. So a slowing down of flow is important when you're trying to accomplish exchange, but then as you get back, as you get deoxygenated blood and you're trying to make its way back to the heart, you start increasing the vessel size and increasing flow in order to keep things moving. All right, so when we're thinking about how this is regulated, there's a few different mechanisms to keep in mind. So there's neural homeostatic mechanisms, endocrine, and autoregulatory. Neural is referring specifically to these things called cardiovascular centers in your brain. There's also some generalized limbic and autonomic nervous system components. We're going to focus on those cardiovascular centers. In terms of endocrine components of regulation, there's catecholamines and kidney hormones. We'll focus on a few specific kidney hormones. Some of these might be long-acting or some might be short-acting in terms of how they regulate blood pressure. And then there's also these autoregulatory components, which are basically local regions of tissue that adjust blood flow. These might involve chemical signals or myogenic controls. So we'll work our way through neural, then endocrine, then autoregulatory mechanisms to control blood pressure. Okay, so in terms of the cardiovascular centers, there's basically a cluster of neurons in your medulla oblongata. They don't look very different from one another, but they accomplish very different things. So there's the cardioaccelerator, the cardioinhibitor, and the vasomotor center. As the name suggests, cardioaccelerator kind of increases heart rate and stroke volume. It's sympathetic in action. The cardioinhibitor decreases heart rate and stroke volume. It's parasympathetic in action and sends signals with the vagus nerve. So if you think back to anatomy, remember that sympathetic is that fight or flight. You have this increased heart rate, you have more action happening, you're accelerating. Inhibition is more, and parasympathetic is more like rest and digest. You're decreasing your heart rate, you're decreasing your stroke volume. With vasomotor, that is tied to cardiac output in that it also affects vessel tone, so kind of whether the blood vessels are contracted or relaxed, and so this also ties into sympathetic response. So the cardiovascular centers respond to a couple of different reflexes or signals. One is pressure reflexes that are sent along baroreceptors. So these are stretch receptors within blood vessels, specifically the aortic and carotid sinuses and the vena cava, and also present in heart chambers, the right atrium. And so they respond to changes in pressure. So if there's more blood volume, more blood pressure, there's a higher degree of stretch. And so at that point we have baroreceptor firing, which refers to the initiation of an action potential, and then this homeostatic cascade or feedback loop. So when you have high increased blood pressure, then there's this baroreceptor that sends that signal. Then you have parasympathetic stimulation to kind of slow that down, drop that blood pressure, and restore things back to normal. When you have decreased blood pressure, you need to get it back up. And so then you have sympathetic stimulation to increase blood pressure and restore things back to normal. So these are acting in opposition to one another. Remember that homeostasis is maintained by negative feedback loops. So you have kind of a deviation and then moving it back to the way it was. The cardiovascular centers also respond to chemical reflexes or chemical signals. So they are connected to levels of oxygen, carbon dioxide, and hydrogen ions, which is related to pH in the blood. Remember that blood has a lot of unique chemical and physical properties. Respiratory gases are an important part of that, and those respiratory gases affect the pH. When you have a lot of activity, that decreases the oxygen concentration in your blood, increases carbon dioxide, and also decreases pH, which I'll revisit in just a moment. When you're at rest, you have a lot of oxygen. You have high oxygen in your blood, low CO2, and a higher pH. So the reason for that, remember, is if you've ever heard of ocean acidification, that's this idea that a lot of the carbon dioxide that's emitted from different factories and from our cars that's contributing to climate change gets absorbed into the ocean, mixes with that water in the ocean to form carbonic acid. It changes the pH and affects ocean chemistry, which has really detrimental effects on all food webs and is really damaging our ecosystems. Something similar happens in our blood. It's called the bicarbonate buffer system. So carbon dioxide is transported in our blood in hemoglobin and red blood cells. It's dissolved into plasma, but it's also becomes carbonic acid and is transported throughout our body in this buffer system. So when that carbon dioxide mixes with water, it forms carbonic acid that dissociates into carbonate ions and hydrogen ions. And remember, those free hydrogen ions affect the pH. And so if you have a lot of them, that lowers the pH. So high CO2, low pH, acidic pH. Low CO2, high pH, more alkaline pH. So when you have the situation of low oxygen, high CO2, and low pH, that stimulates the cardioaccelerator. It inhibits the cardioinhibitor, and it leads to a higher cardiac output. It also stimulates the vasomotor to constrict peripheral vessels. When you are at rest and you have high oxygen, low CO2, and high pH, it stimulates the cardioinhibitor, inhibits the cardioaccelerator, and lowers cardiac output. It inhibits the vasomotor center, which causes your vessels to dilate, so you have vasodilation. So in terms of the endocrine regulators, some of these are acting long-term, some are acting short-term. The catecholamines are epinephrine and norepinephrine. We'll cover those more when we talk about the nervous system. The renal hormones, we'll do an antidiuretic hormone case study when we talk about the kidney system or the excretory urinary system. Erythropoietin and atrial natriuretic hormone we'll talk about later. But we're going to focus right now really quickly on the renin, angiotensin, and aldosterone mechanism, specifically because there's a class of medications that you should be familiar with that relates to this mechanism. So you might have heard of the enzyme renin. It's also referred to as a hormone because it's an important signaling molecule. And so it is secreted from the kidneys and meets up with angiotensinogen from the liver and converts it to angiotensin 1. So you have this chemical change. You then have this angiotensin converting enzyme called ACE, which converts angiotensin to angiotensin 2. So in order for this mechanism to continue, you have to have that conversion from angiotensin 1 to angiotensin 2. What angiotensin 2 actually does is it's a vasoconstrictor, so it constricts your blood vessels. That decrease in volume increases blood pressure and stimulates ADH release, which is important in the kidneys. Antidiuretic hormone is really important for increasing those aquaporin openings in your collecting ducts, reabsorbing water, and kind of manipulating blood pressure accordingly. And it also stimulates the thirst center with the goal that then you would kind of drink more water and contribute more to blood pressure. So this renin, angiotensin, aldosterone mechanism is important for increasing blood pressure as part of that negative feedback loop. And then aldosterone is important for increasing reabsorption of sodium, increasing blood volume, and increasing pressure. So all of these seek to increase blood pressure. That might seem kind of weird, but remember, homeostasis is about balance. Oftentimes we think about lowering our blood pressure, but if it's too low, if we have hypotension, that's bad as well. So this is an important mechanism for our body, but a lot of people struggle with high blood pressure. So if they take an ACE inhibitor as a medication, that's going to stop the conversion of angiotensin 1 to angiotensin 2. And so then you don't have angiotensin 2 to vasoconstrict, you don't have that increase in blood pressure, you don't have that extra ADH release, and you don't have a stimulation of the thirst center to drink more water. So ACE inhibitors stop that conversion and stop this mechanism from occurring, which decreases blood pressure or stops it from increasing further. So this is a summary of how all the different renal control mechanisms relate together. Just something to keep in mind and reflect on when we actually get into the urinary or renal system later in the semester. In terms of autoregulation, remember we covered neural and endocrine, so now getting into autoregulation. Remember that this is kind of localized, so it's at local tissue, and it's happening really at these precapillary sphincters. So as their name suggests, precapillary sphincters are these circles of muscle that happen kind of before this transition from arterioles to capillaries. They control the flow of blood through those capillaries. So when the sphincters are open, it's going to allow blood to flow from the arterioles into the capillaries. If the sphincters are closed, it's going to be redirected directly to the venules. So when you have the signal to open, you accomplish this with nitrous oxide. And that is cued or initiated when you have any of these signals, when you have decreased oxygen, increased carbon dioxide, increased lactic acid, low pH, inflammatory chemicals, or high body pressure. So think about that. Your tissue, if it's deprived of oxygen, it needs flow through the capillaries in order to get oxygen from your blood and give off CO2. And so increased CO2 also cues that. You need blood flowing in order for the body tissue in order to give that away. Lactic acid is produced in situations when you have anaerobic respiration. So if you have low oxygen, you also probably have increased levels of lactic acid. So again, that's a good cue to pull fresh blood into those areas. Low pH is tied to increased carbon dioxide, like we talked about. And when you have inflammation and high body temperature, that's kind of increasing blood flow as well. If you have the inverse of any of those, then you want to constrict blood flow. And so then you have these signaling chemicals or the signaling peptides called endothelins that then close those sphincters so that blood is not actively flowing through as much. So another form of autoregulation is the myogenic response, also called the Baylis effect. So this is kind of how the cells within the vessel, so kind of in the walls of the arteries, respond to changes in blood flow and blood pressure. So it's how stabilization of blood flow occurs within the capillary network. So this is important because if blood flow is too low, then you have ischemia, which can again lead to hypoxia. If it's too high, it leads to vessel damage. And so in this case, when the flow is low, the smooth muscle is going to relax in order to increase that movement of blood, become more compliant, and then it constricts when flow is too high to reduce blood flow. So this is kind of how the musculature, how the tone of the vessel is changing in response to flow. This is going to be important when we talk about glomerular filtration rate later in the semester and talking about the renal system and the urinary system. Okay, so just a few things to keep in mind in terms of clinical considerations. These are kind of ways that you might see blood pressure manifest within a clinical setting. Obviously, we've all heard of hypertension and hypotension. Again, hyper is high, hypo is low, tension is referring to blood pressure. So there's this chart showing kind of like the ranges of systolic and diastolic pressure for low blood pressure, which is hypotension, normal, pre-hypertension, different stages of hypertension, and then emergency pressure crises. And so one thing to keep in mind is that this can change very rapidly. One example of that you might have heard of is preeclampsia, which is a very sudden increase in blood pressure that occurs very late in pregnancy or up to 6 weeks after delivery, so postpartum. Preeclampsia is something that's surprisingly common in the United States, and it affects different people disproportionately. So unfortunately, you still have a lot of people, a lot of women dying from preeclampsia, and it's not always carefully monitored in a hospital setting. One thing that you probably want to consider from a clinical perspective is kind of how you listen to your patients. So I'm sure you've had situations where, you've been aware of what's happening in your body. Other people are maybe not listening or not taking you seriously. And this is a complex issue in the medical setting. One thing is to consider is that preeclampsia occurs in 5 to 8% of all pregnancies, but it's disproportionately high in Black women. And maternal mortality is also disproportionately high in Black women. So this data is from 2011 to 2013. It's the number of maternal deaths per 100,000 live births, and this data is from the CDC. So in white women, there were 13 deaths per 100,000 live births. In women of other races, it was slightly higher, but then specifically in Black women, there were 44 deaths per 100,000 live births. So the way that we've studied and thought about this over time has been kind of different, as we've heard different voices kind of contributing to the conversation. I am going to link this article, and yeah, here it is. I really recommend that you read it and also read more about preeclampsia, especially if you're considering working in an OBGYN ward or doing any sort of labor and delivery care. So I'm just going to read you this quote. Those problems are amplified by unconscious biases that are embedded in the medical system, affecting quality of care in stark and subtle ways. In the more than 200 stories of African American mothers that ProPublica and NPR have collected over the past year, the feeling of being devalued and disrespected by medical providers was a constant theme. Over and over, Black women told of medical providers who equated being African American with being poor, uneducated, non-compliant, and unworthy. So when you have medical providers kind of making assumptions about people and also maybe not listening to them about their pain levels and about how they're feeling, their awareness of their blood pressure and their body, then you have a lot of people dying as a result. And, it's just not how you should treat other humans, but it's a problem that we see again and again in medicine. And like they mentioned here, a lot of it is unconscious. I think there are people who have these biases outright, but a lot of people don't stop to consider who they're listening to and who they're not listening to, who they're putting stock in and who they're not, who they're trusting with their bodies and who they're not. And I think it's something that you as incoming clinicians should be aware of and that you should be actively working to change, understanding kind of what your patients have gone through, who they are, what they're facing just entering the hospital, I think will lead you to be better clinicians. One thing that I can share is that when I had my daughter at the start of the semester, I had a doctor who came in. I had her at Kaiser, and this doctor came in. He never once, really looked at me or listened to me. He directed all of his questions to my husband and just ignored me for the most part. He would ask me questions and then interrupt me and assume that I didn't know what I was talking about or how I was answering. And it was just really frustrating, and this is something that women, and especially women of color, and especially Black women, face constantly in the medical profession. There was also a story that came out not too long ago about a woman who was at a hospital in Fresno who was having her fourth child, and the nurse practitioner was making all these comments to her about how she couldn't afford this child, how she shouldn't be having this child. Just something to consider. This is what's in the data. This is an issue that disproportionately affects Black women. So in order to save our patients and to save people who are human lives who matter, this is what you should be aware of. So preeclampsia, major issue. Maternal death is surprisingly high in the United States, and it's disproportionately high among Black women. Okay, so another couple of things to keep in mind. Hemorrhage is this sudden, really extreme loss of blood. So when you have hemorrhaging, this is not just like a mild fluctuation in blood volume, it's massive decrease in blood pressure and volume. So there's kind of other mechanisms that have to take place in order to restore homeostasis there. Shock, there's different types of shock. In general, this is a condition in which the circulatory system is unable to maintain blood flow to supply tissues for cellular metabolism. Again, there's a lot of different types. This is different from just like being in shock or surprised by something psychologically. There's very specific types of shock. So there's hypovolemic, where you have very low blood volume. There's cardiogenic. There's vascular shock, which might be caused by sepsis. It can be septic, neurogenic, or anaphylactic shock, or then also obstructive shock. So there's lots of different types of shock. Okay, so those are all the slides for the cardiovascular system physiology. I will post the respiratory slides on Sunday, and this weekend I will also post that resource for the lecture exam 1. Please make sure that you look over it and that you see kind of what went wrong. You can pick up your exam tomorrow or next week. So please make sure that you go through that, because those questions, you're going to see a lot of them on the final exam again. So you want to make sure you're learning this material for the final and for your TEAS test.